Welcome everyone to the Apothecary Tales, the basics of pharmacology. So far we have discussed about the insulin sensitizers and insulin secretagogues. Now moving on to alpha glucosidase inhibitors. That is, it includes acarbose, miglatol and voglibose, which is usually used to treat the type 2 diabetes mellitus. Now what is the mechanism of action? Located in the intestinal brush border, these alpha-glucosidase enzymes usually break down the carbohydrates into glucose and other simple sugars that can be easily absorbed. Now this acarbose and miglatol will reversibly inhibit this enzyme, alpha-glucosidase. So when taken at the start of a meal, these drugs delay the digestion of the carbohydrates, resulting in lower postprandial glucose levels. Since they do not stimulate the insulin release or increase the insulin sensitivity, these agents do not cause hypoglycemia when used as monotherapy. And remember, when we try to use this alpha-glucosidase inhibitors in combination with insulin secretagogues or insulin, in such situations, hypoglycemia may develop. And it is important that hypoglycemia occurred due to this combination, which should be rectified with glucose rather than sucrose, because sucrase is also inhibited by these alpha-glucosidase inhibitors. Now this acarbose is poorly absorbed and it is metabolized primarily by intestinal bacteria, and some of the metabolites are absorbed and excreted into the urine. Talking about miglatol, it is very well absorbed but has no systemic effects. It is excreted unchanged by the kidney. Voglibose is a poorly absorbed drug with systemic adverse effects and is metabolized by the liver and has got a negligible renal excretion. The major side effects are flatulence, diarrhea and abdominal cramping. Adverse effects limit the use of these agents in the clinical practice. And patients with inflammatory bowel disease, colonic ulceration or intestinal obstruction should not use these drugs. Next, we are talking about the dipeptidyl peptidase 4 inhibitors, that is DPP4 inhibitors. Coming under that is the allogliptin, linagliptin, saxagliptin and sitagliptin. They are orally active dipeptidyl peptidase 4 inhibitors used for the treatment of type 2 diabetes mellitus. Now, how do these drugs act? Now, they mainly inhibit the enzyme DPP4, which is mainly responsible for the inactivation of incretin hormones such as GLP-1. Prolonging the activity of incretin hormones increases the insulin release in response to meals and reduces the inappropriate secretion of glucagon. DPP4 inhibitors may be used as monotherapy or in combination with sulfonylureas, metformin, thiazolidinediones or insulin. And unlike the incretin mimetics, if you remember we had discussed during the insulin therapy, these drugs do not cause satiety or fullness and are weight neutral. Now talking about their pharmacokinetics, these drugs are very well absorbed after oral administration and food does not affect the extent of absorption. The allogliptin and sitagliptin are mostly excreted unchanged in the urine, and saxagliptin is metabolized via cytochrome P450-3A45 to an active metabolite. The primary route of elimination for this saxagliptin and metabolite is renal. Linagliptin is primarily eliminated via the enterohepatic system. So that means we have already mentioned allogliptin, sitagliptin and saxagliptin's main route of elimination is renally. Therefore, there is dosage adjustments in renal impaired patients for these drugs except for linagliptin. In general, these DPP4 inhibitors are very well tolerated, with the most common adverse effects being nasopharyngitis and headache. Although infrequent, pancreatitis has occurred with use of all DPP4 inhibitors. Strong inhibitors of the enzyme cytochrome P450-3A45, which is responsible for saxagliptin, will actually increase the levels of saxagliptin by inhibiting its metabolism. And those drugs are the ritonavir, atazanavir, itraconazole and clarithromycin. So it is important that we reduce the dose of saxagliptin in these situations. So next we're going to talk about the sodium glucose cotransporter 2 inhibitors. The sodium glucose cotransporter 2 is actually responsible for the reabsorption of the filtered glucose in the tubular lumen of the kidney. And this cotransporter is mainly present in the PCT. So it is mainly responsible for the reabsorption of glucose along with the sodium. And the main two sodium glucose cotransporter inhibitors are canagliflozin and dapagliflozin. So they mainly inhibit this cotransporter and thereby decrease the reabsorption of glucose, increasing the urinary glucose excretion and lower blood glucose. Inhibition of this cotransporter also will decrease the reabsorption of sodium and causes the osmotic diuresis. Therefore, people administered with this cotransporter inhibitor may reduce the systolic blood pressure. However, they are not indicated for the treatment of hypertension. Now, talking about its pharmacokinetics, these agents are actually given once daily in the morning, and canagliflozin should be taken before the first meal of the day. Both drugs are actually metabolized by glucuronation to inactive metabolites, while the primary route of excretion for the canagliflozin is via the fecus. About 1/3 of a dose is renally eliminated. And these agents should be therefore avoided in patients with renal dysfunction. And the most common adverse effects with this SGLT2 inhibitors are the female genital mycotic infections, for example, the vulvovaginal candidiasis and as well as the urinary tract infections and urinary frequency. Hypertension has also occurred, particularly in the elderly or patients on diuretics. This volume status should be evaluated prior to starting these agents. Now moving on to the other agents that is used for the treatment of hyperglycemia. So both the dopamine agonist bromocriptine and bile acid sequestrant cellulum produce modest reductions in the HbA1c. Now the mechanism of action of glucose lowering is actually unknown for both of these drugs. Although the bromocriptine and cellulum are indicated for the treatment of type 2 diabetes, their modest efficacy, adverse effects and pill burden limit their use in clinical practice. So now when we talk in particular about the bromocriptine, which is a dopamine agonist, usually what happens in a diabetic patient, there is always a decreased dopamine activity in the morning, an increased sympathetic activity and as well as an increased serotonergic activity, which will further contribute to an increase in hepatic glucose output, insulin resistance, FFA as well as TAG levels. Now what happens when we try to administer the bromocriptine to these patients? This will reverse all these functions. That is, it is actually increasing the dopamine activity in the morning, decreases sympathetic activity as well as the serotonergic activity. As a result, it reduces the hepatic glucose output, it reduces the insulin resistance, it reduces the free fatty acids as well as the TAG levels. Now when you talk about its PK, usually it is given orally with 65 to 95% of absorption, and it is 90 to 96% protein bound. Its absorption is usually delayed by food and the metabolism is by the cytochrome P3A4 enzyme and is eliminated via mainly the bile as well as to a small extent via the urine, that is about 2 to 6% of it is eliminated via the urine. Now talking about its drug interactions, since it is highly bound to serum proteins and may increase the unbound fraction of other concomitantly used highly protein-bound therapies, example salicylates, sulfonamides, chloramphenicol and probenecid, which may alter the effectiveness and risk for side effects. The concomitant use of dopamine receptor antagonists such as neuroleptics or metoclopramide will actually diminish the effectiveness of the bromocriptine. Now talking about the cellulum, which is a bile acid sequestrant, which is mainly decreasing the hepatic insulin resistance and leads to a decrease in hepatic glucose production, as well as there is a decrease in postprandial glucose absorption. Now this cellulum is thought to be a portal glucagon-like peptide 1 secretagogue with primarily hepatic effects. So we already know the function of the GLP-1, the incretins in reduction of the glucose. At the same time, the bile acid binding by the cellulum leads to TGR5 activation and increased secretion of GLP-1 or other incretins and inhibition of hepatic glycogenolysis. And all of this will further contribute to decrease in the blood glucose levels. So this is all about the oral hypoglycemic agents. So I hope you have clearly understood regarding its mechanism, their adverse drug reactions, their interactions and all. So if there's any doubts, comments or suggestions, please do mail in us. Thank you.